Good morning, everyone. My study is on incidence, clinical profile, management, and short-term outcomes of post-traumatic glaucoma cases. Traumatic glaucoma is a state of an eye which, due to an injury per se or the subsequent reparative processes, has a chronically elevated IOP incompatible with the normal functioning of the optic nerve. My aim was to report the incidence, modes of injury, clinical findings, treatment, and short-term outcomes in patients with post-traumatic elevated intraocular pressure. All patients presented with history of trauma from October 2024 to March 2025 with IOP more than 21 millimeters of mercury at initial presentation or at any subsequent follow-up requiring at least 3 months of EGM or surgical intervention for IOP control was included, and those with a history of glaucoma or already using AGM and with a follow-up of less than 3 months were excluded. And the demographic profile, time lapse since injury, mode of injury, type of injury, modality of treatment, and the number of topical AGM required for IOP control after 3 months were recorded. And the clinical parameters like pre-treatment and post-treatment best corrected visual acuity, pre-treatment and post-treatment IOP recorded by applanation tonometer, slit lamp examination findings, gonioscopy findings, dilated fundus findings, and USG B-scan findings were recorded. All the eyes with open globe injury underwent primary repair of corneal or scleral tear without any other interventions. All patients were started on topical AGM at the time of detection of elevated IOP, and a minimum follow-up of 3 months was there. Coming to results, a total of 58 patients presented with ocular trauma during the study period, out of which 25.86% was diagnosed to have raised IOP. All were male patients with a mean patient age of 45.8 years. And 73.3% were presented within 24 hours of trauma. And most of them, that is 80%, were closed globe injury, and 2/3 of the trauma took place on the patient's residence and the rest at the workplace. And shuttlecock injury was the most common cause of closed globe injury. Glass piece was the most common cause of open globe injury. And 40% of the patients had raised IOP at the time of presentation, 33% raised IOP within 1 month, and 26.7% had raised IOP after 1 month of trauma. And closed globe injury patients had a mean IOP of 38.8 plus or minus 9.2 millimeters of mercury at the time of presentation. After treatment, it had become to 18.6 plus or minus 6.3. And open globe injuries had 38 plus or minus 7.2 millimeters of mercury at the time of presentation and 12.3 plus or minus 6.7 after treatment. And Pearson correlation demonstrated a significant positive correlation between age and IOP at the time of glaucoma diagnosis. 8 eyes had hyphema, out of which 4 eyes belonged to grade 1, 2 eyes grade 2, 1 with grade 3 and 1 with grade 4, and the post-treatment IOP was found to have better controlled in grade 1 hyphema. Dislocated lens was seen in 3 eyes and subluxated lens in 4 eyes at the time of presentation, for which lens extraction was done in 2 eyes and pars plana lensectomy was done on 5 eyes. Dilated fundus examination showed that 12 eyes had posterior segment involvement in the form of vitreous hemorrhage, Berlin's edema, and retinal detachment. Hyphema was the commonest cause of glaucoma, followed by lens-induced, and 2 were with mixed mechanism, 1 with inflammation and 1 angle recession. Hyphema-related glaucoma had a mean post-treatment IOP of 14.8 millimeters of mercury and lens-related 17.4 millimeters of mercury. There was no visible glaucomatous disc damage till 3 months follow-up visit. These were the table I've said earlier. Medical management with topical AGM was sufficient to control IOP in 60% of patients, while 40% required surgical intervention in the form of lens extraction in 5 patients and trabeculectomy with mitomycin C in 1 patient. And the traumatic glaucoma was controlled in 80% of the patients at 3-month follow-up with a mean post-treatment IOP of 17.33 millimeters of mercury on 2.5 medications. And the mean number of AGM maintained in those patients with hyphema was 2. In lens-related glaucoma, it was 2.4. For mixed mechanism and inflammation, it was 3. And angle recession glaucoma required the most number of AGM, but with poorer IOP control. The post-treatment best corrected visual acuity outcomes varied with the timings of diagnosis. Those diagnosed earlier, that is less than 1 month, had relatively better outcomes, while patients diagnosed more than 1 month after trauma showed poorer outcomes, with 25% having vision less than or equal to 3/60. Coming to discussion, in the study we found that the elevated IOP occurred in 25% of eyes following ocular trauma, and the incidence was more in case of closed globe injury. Previous cohort studies done on general population USA showed much lower incidences of 3 to 5%, and study done by Charidat Kalamkar et al. In pediatric eyes had 15% incidence. We have also found that age is an independent risk factor in post-traumatic IOP elevation, as all older patients had higher IOP at the time of glaucoma diagnosis, the same conclusion as arrived by Girkin et al. In a cohort study of United States Eye Injury Registry. Study done by KD Buchikian et al. On incidence and risk factors for traumatic IOP elevation and traumatic glaucoma after open globe injury reported IOP control in 78.1% of patients with mean IOP of 18.2 on 1.7 medications, which is comparable to our study with IOP control in 80% of patients, mean IOP of 17.33 millimeters of mercury on 2.5 medications. Angle recession glaucoma showed poor control, requiring maximum number of anti-glaucoma medications. Limitations were it was a small sample size done in a short study duration. Coming to conclusion, glaucoma is an important cause of ocular morbidity for following trauma. Although closed globe injury is a dominant cause of post-traumatic elevated IOP, open globe injury is also associated with late onset IOP elevation, and careful follow-up is needed. A significantly correlated with higher IOP, indicating that it is an independent risk factor. Medical management is successful in controlling IOP in majority of cases. Timing of trauma presentation and glaucoma diagnosis do not significantly affect the treatment modality. Thank you.
Just one question. At what point of time you measure the IOP in open globe injury?
After their repair, and I've included them in less than 1 month group. IOP diagnosis in less than 1 month.
Both groups are not comparable.
Right, it seems good. And what methodology you used for IOP measurement?
Application tournament.
GAT. You used GAT in all these cases.
Yes.
And slowly try to add the management pattern into the groups, like how many needed an IFEMA wash, how many needed a peripheral hydrotomy, how many needed definitive lens surgery, how many needed AG surgery. Like that, if you add, then this will come good. Trying to look at post-traumatic IOP rates is an important issue. It's an important issue. So probably this study is good. We'll advise you to do that as a continuous study.